Hello.
Hi, Sydney. How are you?
Fine. How are you?
Good. Do you want to test your camera to make sure you can show your video?
I don't have a video.
Oh, you don't? Oh, no. So we can see you on camera. Sorry.
Oh, yeah.
There you go.
Oh, you'd already. I was
Sorry,
automatically.
I didn't mean to give you a heart attack.
I was automatically muted. Not unmuted myself, but I didn't stop. I didn't start video. Yeah.
Yeah. We do have everyone automatically muted when they come in. Okay, and then Sydney, I'm sharing your slides. That's correct, right?
Yeah. Yes, please.
Okay, and just go ahead and say next slide or whatever you want to do to have me advance.
All right. Did you guys do anything to them? I think Asher was. You gonna fix something?
It doesn't look like it. They're black and white. I can show you what we have.
It's boring, black and white, boring, but boring, black and white, and
or simple or simplistic, modern.
Simple.
There you go.
Yep. So I've got them all in here.
Wonder if I can read those without my glasses. I almost can. There you go.
I know I have a hard time. Like I wear my glasses sometimes and then I take them off and my eyes are all messed up.
I know, right? Like it's so much worse.
Yes.
Hi, Sydney. I'm Kim.
Hi. Hey, Kim. How are you?
How are you? Good.
And I see we've got Ted and we've got Asher.
Hi, Asher.
I'm going to make you all co-hosts.
I'm sorry that I accidentally lied to you, Sydney. I didn't see perhaps the single most obvious button on the page of registry information for the Zoom meeting.
Oh. Oh.
And when Shelby pointed out to me where it was, I promptly felt like a damn fool.
Oh, okay.
Well, you know, it's not, I feel like it's not obvious though. Like you kind of have to know where you're going to see it.
Well, thank you. Well,
So I wouldn't feel so bad, Asher.
Ed sent me the link anyway, so I have it double. I have a double link.
Perfect.
Hi, Ted.
Hello.
Hey.
Ted, do you want to test your screen share at all, or are you good?
Sure, let's do that. Let's do that thing.
Okay, so you're a co-host, so you should just be able to share. Looks good.
I have too many slides. We'll have to actually present this fast.
How many?
I hope we have fast readers.
How many people are registered?
I think we have
50,
close to
right?
50. Yeah, close to 50.
Oh, cool.
Oh, good.
I can double check while you guys are.
So Ted, I'll just stop when it's time for you to present. I'll stop my share and then you can go ahead and start. Or if I am slow, you can probably just take over my share screen too.
give me the hook.
Yep.
And likewise, whoever's after me.
On the subject of slides, Shelby, if you want, when we get to the end and there's all of the links we've listed to put in the chat, I can get all of those posted so that, because I know you've got several slide transitions there.
Yeah, that'd be great. Yeah, if someone else could
Seven
post
different-
anything in the chat, since we're kind of like showing slides consistently, that'd be great.
Yeah, I can just monitor the chat the whole time.
Okay.
Take that off your plate.
Perfect. Yeah, usually if I get a break, I can do it, but we have a lot of slides.
Many things.
They look really good. Jackie did a good job on them.
Yeah, Jackie killed it.
They do look good.
Aren't they pretty? Okay, so I'm.
All right, I'm going to check off who we've got here so far.
Should we let Crystal Stevenson in?
Oh, yes, we should.
I mean, I don't know though, Shelby. That Crystal Steve, I've heard she's kind of a troublemaker.
It was iffy, Crystal. We weren't sure if we should let you in or not. Now we've got Sarah coming in.
Hi, everybody.
Hello.
Hello. I just texted the group. Not everybody. Crystal, I have you on a separate one, but this way, in case there is an issue, which hopefully there won't be, and there will be no glitches. We all have that text string in case we need to reach each other that way.
So at this point, we're just missing Matt, Kamal, and Vicky. Oh, and Sharmili.
Sharmili. I don't know if Sharmili's going to come on early though.
Oh, okay.
I think she'll just be on the call.
Yep.
When we announce her, right? I'm pretty sure. I don't know, Asher, if she mentioned anything to you, but
She didn't mention anything in particular, but that makes sense.
Okay.
If she doesn't actually have,
A part, right? Yeah.
Part.
and same with Vicky, she'll be on at one point. Hi, Sarah. How are you?
You're muted.
Hi.
Hello.
I realize now in this shirt that I look like I might be Mrs. Roper from Three's Company, but I'm gonna
Looks
keep
good.
it on.
I don't know if everybody on the call knows who Mrs. Roper is, but
Well,
that
and
is
to
Oh,
make
I
this
totally know who Mrs. Roper
love
is.
it. Yeah.
make this even funnier, I had an eye appointment about an hour ago, and he's putting drops in my eyes, and I said, "This isn't. You're not."
Did you get him
Dilated.
dilated?
Oh.
Oh yeah. So I can't see you all if I don't have on these readers. So,
I
no.
love it.
but they were already in my eyes. So what was I gonna do?
Yeah.
Sydney and Ted, how are you both? And Crystal,
Good,
great to
good.
see you.
Great.
Do you want Shelby to pull up the presentation at all, Sarah and Crystal in particular, just to see it, or are you good? Or
I think I'm in. Sure. It
Okay,
doesn't hurt to
yeah,
look at it
I've
again.
got it right here.
and then I know Asher did a great job on that show flow, and I think
It's
everybody's
great.
got. Yeah.
I got it printed out so I can keep track.
Me too.
Yeah, I've got it printed and on my screen. Okay, so I'm just going to kind of scroll quickly through the slides, starting with the intro. And then we've got Sarah, housekeeping, schedule,
Look at those two youngsters.
There you go.
right?
No, Ted is a youngster.
Introduce Sydney, and then we've got
Yep.
Sydney slides. I'll quickly go through those. And then Ted will take over the share screen. And then we'll come back and we have lifetime achievement, which I think is that Matt
Yep.
introducing.
And Kamal. So Matt will introduce.
Mhm.
Yep.
So we'll do Matt, Kamal, and then Vicky. And then we have Crystal. And then Sharmili. And then at the end, we've got sponsors.
Anna is coming in, somebody.
And that's it. Anna, I don't think, she doesn't need to come in early, I don't
Can you
think.
go
So I'm
back?
just-
Oh, I'm sorry. Can you go back to a few of the spot? I just wanted to see the sponsor names really quick. So
Yeah,
not
oh
that-
yeah,
no,
let me start from the beginning.
just so I know that I can say them all, the names.
Well, and according to the show flow, I
Oh,
think the
that's right.
only ones that you announce are the partner
Yes,
level,
That's
Sarah.
right. You're right.
Yeah.
Thank you. Thanks for that reminder.
Mm-hmm. And then the other ones will just show on the screen.
Great.
I'm gonna say thanks to our advocate sponsors, thanks to our supporting sponsors.
Mhm.
Perfect.
Yep. So
And
those are
Ashley,
the only
you're-
ones that you really have to say.
Okay. Sounds good.
All right.
So do you want me, I know we've left 10 minutes to kind of, until we start formal introductions. If it seems like a lot of people are on within the 5 minutes, do you want me to get started, or does somebody want to just send me a little Hey, yo, go ahead and start.
Shelby's muted.
Yep, I am. Yeah, and also, Sarah, you can, since you're a co-host, do you see in the participants? Do you see your participant list?
Yep. Yep.
So you can kind of see once people,
Great.
you can see who's in the waiting room. And then when they come in, and we do have, I think, close to 50 registered, but that does include us. So, you know, maybe when we get to like 30 or 40, we can go ahead and start.
Sounds good. And for those that know this person, I talked to Mike McDermott earlier today, and he sends his regards.
Oh, wow.
He's still strumming.
Yeah.
Is he in Chicago or?
No, in Wisconsin. Yeah.
Yeah.
Where Wisconsin?
He's about an hour and a half. It's called Black Earth. It's like a farm area type thing, west of Madison, about an hour or so west of Madison.
I could remember that's where we had our retreat for the Chicago plan.
Was it?
Yeah.
At his place?
At his home,
It's a great house. It's great.
It's beautiful.
Yeah.
Beautiful country.
Yeah. I have to check his pulse every so often, make sure he's around. For those that don't know, he is a county long, I don't even know how old he is now though. Late 70s, I would say.
Probably so, yeah.
You'd hear him dropping a lot of F-bombs over the walls at the county Fantas clinic with his patients. The staff would get so mad at him because he'd run so overtime with his patients, but people loved him and he's hysterical.
So when we go on at 6, is everybody going to be up? Remember Anna was sort of writing about that, Asher.
I thought you were going to spotlight different people as people are on. You're going to like have like featured. That's
what we're going to. I think that's what we should
do. I'm spotlighting anyone who's speaking.
Perfect.
Yeah, but sometimes if they speak and it gets automatically spotlighted, you don't want that to happen. You want to be intentional about who's spotlighted.
Yeah. I was just looking at the housekeeping. So, we are still going to ask people to turn off their video. Is that right?
Oh, are we?
I don't know. You know,
or should I change that?
I believe that I don't.
I would change it.
That went.
I would love to see
I can't change it. It must be an image.
At this point, what does it say in the slide? Yeah, the slides are all images because they were all built in Canva. If it says we're asking for that in the slides, then that was the eventual decision that we went with.
It says please be sure to mute your audio and turn off your video during the presentation.
Maybe say turn off your video if you don't want it on.
I'll say that.
You know, instead of saying do it, just say
right.
Don't.
Yeah, I can say that
video. Because some people actually don't. They could be in their PJs already. Who knows?
True.
Okay, so we have a couple people.
Sydney, looking through your slides was so nostalgic.
Right. It was like, oh, we did that. Oh, somebody did that. Oh, somebody did that. Oh yeah,
well,
about that.
When I worked for Kevin Weiss, when I first moved to Chicago, Dr. Addington, our server was named Whitney after Dr. Addington. It's so
that's funny.
And his mother's name was Sarah, and his daughter's name was Sarah, and so he was always a absolute sweet man. I just can't believe he was still alive. You know, when you're 20 something and you meet these people, you think they're already 80 years old.
Have you had any contact with Kevin? Has anybody had contact with Kevin?
I saw him at Michael McDermott's wedding like several summers ago, pre-pandemic. But other than that, I have not. No. I don't think he's retired yet, though.
No, he's not.
Now, I only see 2 people in the waiting room. Is that?
Yep, that's all I see too.
Okay, great.
Usually they had six to like 6:02.
Sprague doesn't want to be mentioned anymore. Jim isn't.
No, they just don't, not as a sponsor. Asher has it in the notes.
Yeah. So
So-
at the top of the show, whenever you see that Jim has hopped on,
Yep,
do your
he's on.
casual like, hey, I mean, like, hey, you guys helped us get started. Thanks so much. We're so glad you're here.
Okay,
And at the end, they're on the community sponsor
Yes.
slide because the community partner slide because they are a community partner. But we don't want to mention them as like an event sponsor because
Okay.
they're not, and they specifically were like, we don't sponsor events. We
And-
don't
oh,
do
I
that.
gotcha. Oh, okay, okay.
But
But I can say, you know, Jim, it's so great to see you. And for those that don't know,
yeah,
Jim
exactly.
leads the Sprague Institute who
That's-
helped fund. Yeah, okay,
Perfect.
great. Okay,
Mhm.
Really perfect.
The only ones that really need the verbal recognition are the
AstraZeneca and all those.
bigger,
Yeah, it's on
partner
Or
sponsors.
the first one. Yeah.
the Asthma and Allergy Foundation of America, American Lung Association, Northwestern's, Rushi's group, and then the American Asthma and Food Allergy Association. Great.
Mhm.
So this is being
Sorry,
recorded.
I listed the American Asthma and Allergy Association twice.
What's that?
This is
Somebody
going to be
has-
recorded and it's
Is-
going to be on the website. Is that right?
Mhm.
Yeah.
Yes.
I think it's recording now, so will
Not
someone
this
just
one.
edit out? the
Yeah,
start?
we'll just edit
No,
the
this
Okay,
will be
great.
done.
beginning off.
Careful what you say.
We don't need to bore people with our
Okay.
chatter.
Stop swearing, City.
Sarah?
Asher will make sure too that everybody, if we'll send out an announcement and a copy and all that good stuff. We'll get Jackie to follow up with all that.
Yeah. Sarah, I apologize because I
Okay.
only just now noticed that
Okay,
I listed the AAFA twice in that list of names at the end there,
oh, I see.
but
No.
conveniently, the one that's wrong is the one at the end. It's not the American Asthma and Food Allergy Association. It's just the Asthma and Allergy Foundation of
Oh, okay.
America.
Wait, hold on.
So you can-
So can I read this off to you? So there's the Asthma and Allergy Foundation of America,
Yep.
the American Lung
American Lung
Association, the Northwestern University Feinberg School of Medicine Center for Food Allergy and Asthma Research, and then the
that's it.
asthma, and that's it.
That last one there, that was wrong
Okay, perfect.
because
I gotcha.
I must have got excited. Tried to put them in there twice.
No worries. They're so great that we
Lab
put them into.
Bad.
So we have 3 minutes, right?
Mrs. Redding is on. She's so lovely.
And Shelby, I know you'll be are you going to give us like the minute warning so we're all
Yep.
quiet?
Mhm.
And then Sarah, you'll come on and start doing your fun stuff that you do.
Yep. Is the glare too bad with my glasses if I'm looking straight at you all?
No,
Okay, great.
mine is not good.
Well, if I look up at my screen, it's awful. But
So Shelby, you're advancing my slides. Is that right?
I am.
Okay, good. Bye.
Yep. Just don't forget to tell me to advance.
Because you can't tamper.
I mean, most of the time I can tell if people are, reading the slides, but sometimes it's hard for me to know when to advance.
Ted, how old is that little?
3
Nugget.
years old.
Really, it looks
Aw.
like a little kitten. It looks like a baby.
Oh, small.
It's a Cornish Rex that only has an undercoat fur, so it's like almost like
Oh, really?
Did you say 23 years old or three?
three.
Okay.
23 would be incredible, though.
I had a friend who had a cat for 26 years.
Yeah, they
Oh!
can. Indoor cats can live a long time. Yeah.
Take that cat to the bar.
Right.
I wish
Definitely
dogs
older than
lived that long. Oh.
Yeah, me too.
Great. Mountain cat.
I want to try to be able to see everybody as we talk, but the glare is so
All right. We've got
bad.
about 2 minutes left.
For me to revise my slides.
Yeah. No, Matt. Was he supposed to join us early?
He maybe,
He knows that he's got a speaking role.
Okay,
did.
so I guess
he has
if for some
that
reason,
knowledge.
yeah, if for some reason Matt and Kamal do not, okay, Kamal's in the waiting room, I see. I don't see Matt yet.
I just texted him.
Okay, so if he does not hop on, Sarah, would you feel comfortable just introducing Kamal?
I sure would.
Okay.
Matt actually sent me how to say his last name, so that's hopeful.
Okay, does anyone have any last minute questions? Otherwise, I'm gonna let everyone in.
I'm gonna mute.
Yep, I'm gonna mute. I'm gonna hide my video, so you'll just see the Chicago Asthma logo, but I will be here.
Good evening, everyone. Thank you so much for joining. We're just giving folks a few moments to jump on this evening, and we'll get started shortly. Thanks to so many of you who have joined already. Good evening. This is Sarah Rittner, MC for tonight's event. I just wanted to let you all know, if you can hear me, that your sound is working well, and we'll be getting started shortly. Thanks so much for joining. We're really excited to begin. I'm just going to again welcome folks that are joining us and say thank you so much for being on today. I welcome you to please go ahead and enter your names and your professional or personal jobs. I know that it's a little blurred these days with the pandemic, as well as your time spent with or in affiliation with the CAC. I want to note special attention to my very first program officer who was on, Mr. James Alexander. I was quite young when I met Jim for the first time as a research assistant at Northwestern, and our thanks to the Sprague Institute for actually starting the CAC all those years ago. So I guess I can't hide my age with this being the 25th anniversary, but it's really good to see your face, Jim. I hope you're well.
Happy to be here.
Yeah, so please feel free to just add your great. I could see Erica, thanks for joining. Christina. My sister who is trolling me as she participates, which is so nice of her. Hi, Nikki Wolverton. Speaking of phenomenal partners, Nikki Wolverton from the Public Health Department, the State Public Health Department, who's been with us for so long. And good evening, Ms. Redding. I hope that you and Mr. Redding are doing well.
Good evening, Sarah. Thank you so much.
Good to see you.
You too.
What's really exciting to see a lot of the folks joining us today. I was mentioning to the planning team that it felt a little bit like This Is Your Life, or something to that extent, reading through some of the slides that'll be reviewed today and all the years of hard work and movement that has happened through the CAC over the last 25 years. So really excited to get started in a few moments. We're just going to give a couple more minutes, or a couple more seconds actually, for folks to please introduce themselves via the chat. We're expecting a large crowd today, and it looks like we're already close to that. So we'll be started with our formal presentation in just a few moments. So just as a reminder to folks too, we are recording today's session, and I don't mean session as in another Zoom that you're participating in, but today's celebration is what I should say. And I would love to formally welcome you all to the Chicago Asthma Consortium's 25th anniversary. Looking back at how CAC has impacted asthma health over the last quarter of a century and looking forward. We can go to the next slide, please. I'm Sarah Rittner. I am the founder and CEO of a very small, just myself, consultant, health equity consultant company. And I have been a member of the Chicago Asthma Consortium for just under 20 years, which is the amount of time I've lived here in Chicago. As I was thinking about introducing myself and welcoming everyone today, I just have to speak to, like I did a little earlier for folks that weren't on, to individuals like Jim Alexander and some of the other Kevin Weiss and folks that are going to be talked about today, because I came to Chicago 20 years ago as an asthmatic, as a person that studied what we now would call health equity, and I had no idea what I was going to do with those two things in my life. And I went to a job fair at Northwestern University, and someone said, well, you know, we're looking at asthma in some of our urban communities, and we need some research assistance. Would you be interested? You speak Spanish, you know, you this and that. And lo and behold, here I am 20 years later, getting to kick off such an amazing event. I've been a member, I've been on the board, and I've even gotten to lead the board for a little bit of time. And so I'm really grateful to everyone for being on today, and truly honored to be able to MC tonight's event. Next slide. Just a little bit of housekeeping for today. If you would like, well, for sure, please make sure to mute your lines. I think we have you all muted. But you also are welcome to be on or off video. We want people to feel comfortable. We realize it's the evening time. You might be juggling a number of things at your home, but we would also love to see your face, or at least I would, during this. So please feel free to use your video if you'd like. We also have the chat feature available to introduce yourself as we have been, also to say hello to other attendees, share memories from CAC's history. We can talk about how we all look after 25 years of doing this. I'm sure I look exactly the same as I did as a research assistant, but please feel free to use your chat as you'd like. Also, just at the bottom of the slide here, you'll see the contact information for some of our colleagues that are helping to run tonight's event. And please feel free to chat or text them or call them. I think just call. I don't think that's a text number. So either you can chat or call them if you're having any technical issues or have any questions specific about tonight's event. Next slide. So a little bit about the schedule for tonight. After I'm done here, I'll be introducing my colleague, Dr. Sydney Parker, who's going to talk to us a little bit about the history of the Chicago Asthma Consortium and accomplishments in asthma. Then we'll turn things over to Dr. Tenderakis, who's going to talk about actual kind of clinically asthma then and now. Then we have some awards to present, including our Lifetime Achievement Award, our Recognition Award. Next slide. I know there are more awards. Oh, I thought there was one more award. My apologies. You could go back one. And our Recognition Award. So it's my pleasure to introduce our first speaker for the day, Dr. Cindy Parker, who is a Senior Director of Grants and Awards, was the Senior Director of Grants and Awards at the American College of Chest Physicians, and is a lovely colleague and friend. Cindy, I'll turn it over to you.
Thank you. So thank you for this opportunity to participate in this celebration of the CAC. My presentation today will be focused on my experience of the CAC, but the history of any coalition in a city as large as ours can only really be told by the participants themselves. There are so many stories that I'm unaware of that you all know, and the partnerships that have been formed over the years need to be documented. So let's go to the first slide. So the CAC was first organized by the American Lung Association of Metropolitan Chicago, later the Respiratory Health Association, and the American College of Chest Physicians, the organization that I was working for. It was the first organized asthma coalition that had a variety of stakeholder partners rather than just one program. It provided an inspiration and a model for many other communities to address asthma. It was sponsored by the Otto Sprague, S.A. Sprague Memorial Institute, which is a local Chicago-based foundation, and more about that later. By 1998, we had over 350 members, all coordinating the efforts of individuals and institutions to provide synergy among all of our efforts. Next slide. So to put this into context, I think it's important that you see how the CAC fit into a larger national asthma education effort in 1996. The National Heart, Lung, and Blood Institute is a major funder of asthma research, and in 1989 had established the National Asthma Education Program. I was working at NHLBI at that time in the lung division, and was worked with the coordinating committee to get the coordinating committee established and to work with the first guidelines committee. The first guidelines, someone else took over the actual coordination of developing these guidelines, but they were published in 1991 and have been redone several times since. The National Asthma Education Program Coordinating Committee had about 20 stakeholder organizations and agencies, including federal agencies and national organizations. Also, the National Institute for Allergy and Infectious Diseases supported research on the allergic aspects of asthma. And through that, Kevin Weiss headed up the National Intercity Asthma Study. Next slide. So Kevin, Dr. Weiss came to Chicago to work for Rush and to work for Dr. Whitney Addington. And the two of them proposed to the Sprague Institute that it focus its funding on a particular problem in Chicago, which was the epidemic of asthma, and to fund several programs simultaneously. Dr. Addington was a major figure in asthma in Chicago medicine, serving on the Board of Health as well as on the Sprague Board, in addition to many other roles he held in the city. Then I moved to Chicago in 1994 to work for the American College of Chest Physicians in health and science policy, organizing clinical practice guidelines and later coordinating patient education and diversity programs, as well as pulmonary critical care workforce programs. Next. So the two organizations had a very strong interest in asthma, the American Lung Association of Metropolitan Chicago and the American College of Chest Physicians. And together these two organizations founded the CAC with funding from Sprague. The long-term funding from the Sprague Institute was really critical to its success. And Jim, thank you very much for consulting with us for many years on our organizational strategy. That was very helpful to the early days of the CAC. Subsequently, the CAC received some funding from the National Heart, Lung, and Blood Institute, which was part of a multi-year program demonstration project with 6 other coalitions around the country. Other support over the years came from IDPH, pharmaceutical companies, and many other sources of specific projects. Next. The initial goals were to raise awareness among the public and patients and practitioners that asthma is a serious disease, ensure the proper diagnosis and treatment of asthma, to facilitate access to care for asthma patients regardless of income. And in my book, probably the most important one is to foster partnerships among patients, caregivers, healthcare providers, and community organizations to improve care of asthma. Next. So there were 7 initial committees. The Access to Care Committee hit the ground running with the Chicago Emergency Department Collaborative. And they worked with the Chicago Asthma Surveillance Initiative, which was also funded by Sprague and headed by Kevin Weiss. The Community Committee has now morphed into the Community Advisory Board and has been an essential part of CAC work from the very beginning. The Data Committee held for many years annual data conferences where researchers could discuss early data that they have or reports of data on asthma in Chicago. It has been a wonderful way of networking among the researchers in Chicago. The Marketing Committee created the Chicago Asthma Resource Directory, which was a map, online map, so patients could find clinics that would treat asthma. The Marketing Committee also headed some press conferences, and Vicki Persky, Dr. Persky was the presenter at, I think, the first press conference that the CAC ever had. The Patient and Public Education Committee evaluated hundreds of patient education materials and provided information on the website. And of course, the Professional Education Committee has had many quarterly meetings that offer updates on the guidelines and other specific topics, and created a speaker's kit. The School Education, the School Committee was really integrated with the CPS very early, helped to change the policy about children carrying their inhalers in school. They had programs for principals and other staff, encouraged safer pest control and cleaning programs in schools, and did a poster for school nurses on emergency management. Next. So a major accomplishment, I think, has been to foster the partnerships among the members with some innovations and research and outreach programs. CAC has promoted data surveillance on asthma, has promoted the value of community health workers, thoughtful discussions of asthma policy, healthy homes and asthma-friendly construction, the use of IEPs in schools, and many other projects too numerous to mention. And the CAC has played a vital role in the Illinois Asthma Partnership. Nationally, it was also a big influence on the development of other asthma coalitions. They really took off after 1996. At one time, it was estimated there were over 200. There was a supplement to CHEST in 1999 that I think made CAC a little more famous, called Asthma in Chicago, which described the rationale for the CAC in its early work. Over the years, it later became an independent 501c3 organization with an executive director, a staff, an office. And subsequently, it's been managed by either a consultant or a contracted association management consultant. Next. So I have to say that the American College of Chest Physicians continued its interest in promoting the CAC and supporting local asthma coalitions around the country. We held an asthma coalition symposium for many years, for 15 years, which included an update on CAC activities, as well as an opportunity for other coalitions to share their ideas and their successes. As it turns out, the first symposium was in Chicago, and the keynote speaker was Sister Sheila Lynn, who is Commissioner of Health, which just goes to show what clout Whitney had, Dr. Addington had. So also the ACCP Chest Foundation in 2000 supported a survey of asthma coalitions. Of those that they surveyed, 75% of them had been formed after 1996. The Chest Foundation also supported the development manual for asthma coalitions that promoted best practices for coalitions. Next. So there's no doubt that CAC has been used as a model and an inspiration for the development of other asthma coalitions. The Association of Asthma Educators has surveyed the field, and as of 2019, there were over 100 coalitions. Just recently, I did a quick Google search of asthma coalitions, and there are dozens of coalition websites that are beautiful with lots of information about the local resources, and many of them have been institutionalized into state, county, city, and regional health systems, or into local lung associations. So, but I'd also like to say the influence of the CAC on Chicago. I think those of us on this call can say that participating in the CAC has given us all an experience that you will carry throughout your career in bringing together a variety of diverse voices regarding fighting asthma in the city. So many CAC and former CAC members and committee members and leaders are now in very important positions of authority in this city. And I know that they have taken the experiences of hearing a wide variety of voices to their next position. And it's hard to quantify that, but I know that's the case. What I've described now is really only a fraction of all the activities that the CAC has done over the years. We have world-class medical institutions here. We have world-class asthma researchers here. And the CAC has participated in many asthma research programs. But many more partnership or collaborative projects and voices need to be heard. I would suggest that the CAC invite submissions for CAC stories. Those of you who have developed partnerships, describe those partnerships very quickly to just document them, because we don't know all the things that have happened. So I would challenge the CAC to pull together a list of CAC stories. Thank you.
All right. Well, thank you, Sydney. That was incredibly informative. And as somebody who has benefited greatly from having the CAC the whole time that I've worked on asthma in Chicago, thank you to you and everyone else who was involved in the founding of this organization. It's incredible to be able to benefit from the knowledge base that all of you put together. And as you said, the partnerships that were fused by being able to collaborate through the CAC and by sort of setting an example of having a system that works together instead of in competition. So I'll just throw that out there. I'm supposed to be doing something else right now, but thank you. I appreciate it. And on that note, I also want to introduce our next speaker, Dr. Narakis, to just sort of give a keynote for us. And I won't go into Dr. Narakis's extensive history with CAC, although I hope he'll outline it a little bit. But for those of you who don't know him, Dr. Narakis is an expert in pulmonary conditions, including asthma, adult cystic fibrosis, and chronic obstructive pulmonary disease. He specializes in pulmonary function testing to determine the cause and severity of complex lung disorders, and researches strategies for improving care for asthma, COPD, and cystic fibrosis. And so I'll actually leave it there, and I'll just kick it over to Dr. Narakis, and thank you very much for being here.
Thanks for that introduction. So I'm very pleased to be here. Thanks for inviting me. It has been a long road. I was at the CAC from the very beginning. Actually, was one of the signatories on its documentation to become a 501c3, and was one of the early presidents of the board. But it's a real honor to be invited to speak. So basically, what I'm going to talk about is how asthma's changed over the history of the CAC, and over 25 years. That's a quick period of time, but a long period of time in medicine. So basically, 25 years, basically everything that happens in written in a medical textbook is wrong by the end of that 25 years. So this will be sort of a whirlwind tour of those changes. I'm going to redo my screen share because apparently I'm not getting the control. So 1 second here. Let me try this and see how it works for us here. There we go. So what's changed in asthma over the last 25 years? So basically, guidelines have been revised 4 times. And again, our approach to asthma has changed in the equivalent way during that time. The medications, and more importantly, the medications and how we use them has changed, specifically in terms of how we use drugs such as long-acting beta agonists, long-acting antimuscarinic agents, the changes in propellants and spacers, and the new advent of biologics that have really sort of exploded in the market in just these last few years. Also, our approach to the social determinants of health, both the environment and asthma, and also more recent knowledge on adverse childhood experiences and how that has impacted the health in childhood and adulthood. So here are the medications that we had when I was a early professor at University of Chicago. We had Beclevent, we had Batzeril, we had a triamcinolone inhaler that came with its own spacer device, and then we had the a sort of a mint flavored inhaler as well, thinking about the idea that the sort of that menthol flavor would sort of help. We also had albuterol. This is labeled as H of A, but it looked very much the same when it was a CFC inhaler. We had Intol, Cromolyn, and also Theophylline was in common use at that time. So again, these were sort of the tools we had at that time. But again, at the time, they actually represented a revolution in care of asthma because they sort of underpinned the idea that asthma actually, rather than just being a disease of bronchoconstriction that can be treated with bronchodilators, was actually a disease of inflammation that required anti-inflammatory therapy such as inhaled steroids and other agents to try and treat that inflammation. With that understanding, as Cindy discussed, the National Asthma Education Prevention Program came out with some guidelines to help sort of change the practice of asthma across the country. And again, the first one came out, as Cindy told you, back in 1991, with a major sort of revision in 1997, right around the time that the CAC was founded. And again, this is the guidelines that really drove a lot of the early work in the Chicago Asthma Consortium. The 1991 report basically was the first edition, provided evidence recommendations on objective measures of lung function, environmental control measures, comprehensive pharmacologic therapy using a stepwise approach, and a big emphasis on patient education, especially partnership with the patient to manage asthma. In 1997, the expert panel report number 2 was updated and revised, basically further defined the inflammatory basis of asthma, recommend long-term controllers and quick relief medications for the treatment of asthma, include some newer controller medications. Again, this is the when the stepwise approach came to asthma. This was a sort of major breakthrough at that time, and broke asthma down into sort of 4 different categories based on severity in order to guide therapy. So again, the step 1 is sort of intermittent asthma, was certainly first termed mild intermittent. And basically, the people had symptoms less than 2 times a week, or waking up less than 2 times a month, had normal flow, and only had very brief exacerbations. Mild persistent asthma is patients who had symptoms, a few times a week, but less than daily, had some decrease in activity, and again, still had fairly normal lung function. Step 3 was moderate persistent, where you had daily symptoms, and really was the group that required sort of a chronic therapy to suppress inflammation. And then severe persistent was patients who had continuous symptoms, frequent exacerbations, frequent nighttime symptoms, and again would require more therapy. The idea was using these various asthma steps. You would step up therapy when asthma was worse, and then step down therapy when asthma was improved. And again, with this came a sort of series of recommendations for therapy. And again, this slide is fairly busy, and again, would take a whole sort of lecture just to go through any of these guidelines. But basically, they broke things down into what long-term therapy you needed, what sort of quick relief therapy you would use, and then again, what teaching was required for each of these different severities of asthma. Step 1 was intermittent asthma. So again, you didn't need a daily medication because your asthma was intermittent. It really centered around short-acting bronchodilator therapy. But as you can see, there is a lot to teach. And again, how you manage, and again, in some ways with mild intermittent asthma, the recognition of when you were having an exacerbation, when you need to do more therapy was a key step. Mild persistent was a group that required some daily therapy. And again, there were a lot of choices then, even back then. In children, often aiming towards cromolyn or things that were blockers of histamine release that did not contain steroids due to the concern for growth suppression with steroids. Theophylline was still used back then. The early leukotriene therapy, zirpulclast or Silutin, were also available. Basically, short-acting therapy was about the same. And again, these additional teaching steps were added at this step of asthma. With more severe asthma, step 3, moderate persistent asthma, this was the first group that required a daily inhaled steroid. And basically with other things perhaps added. The quick relief medication was just still short-acting beta agonist therapy. And again, how often you use that would sort of determine whether you need to titrate up or down your chronic therapy. Again, education was, in addition to the steps below, added teaching self-monitoring as well as additional education. And then step 4 was severe persistent, where you would use daily medication, high dose and inhaled steroid. And again, actually recommended sort of chronic corticosteroid tablets, which we don't do anymore. Basically with the idea that you want to try and get off those as much as possible due to side effects. Again, Sydney talked about how a lot of what we did in the early CAC was data-driven, and one of the goals that we had was to sort of popularize and educate physicians in the city about the guidelines in order to improve asthma care. I did get a grant from Otto S.A. Sprague Foundation to actually study asthma in Chicago, and actually looked into pharmacy data as a way to see how asthma is being treated throughout the city. And again, those of you who were with me early in the CAC remembered a lot of maps that I would show at the early data conferences, looking at geocoding of asthma care. This is one of these graphs looking at a group of patients aged 9 to 17, and the source of data was pharmacy data from Walgreens at the individual level, and basically looking at, for people who are using beta agonists on a regular basis, were they also using an inhaled steroid? with the idea if you're using daily beta agonists, you are in that moderate persistent category that should be on an inhaled steroid. And looked at it by a zip code level where you could see what areas of the city were having the greatest problems with asthma. And again, did this, using various data sources. And the other groups within the CAC, so Vicky Persky, for instance, was working on various community plans. And again, that was the beauty of the CAC. It wasn't one program, it was coalition programs. So one of these was the Chicago Community Asthma Program, or CAC, which was a group that's a multifaceted program that was aimed at improving identification of individuals with asthma, and also introducing designs of interventions to better manage asthma care. Again, I use that data from Walgreens and other sources to actually look to see the effectiveness of these programs, and was able to look at the intervention area, which was the old Region 4 of the CPS, Chicago Public Schools, where the intervention occurred, and was able to compare the effects of that intervention to other sort of matched areas of cities to show the odds ratio for appropriate inhaled corticosteroid use, and how that increased over the years of the intervention in a significant fashion. So again, that resulted in a paper in the Journal of Urban Health that sort of went into that technique. If people are more interested in the sort of logistical regression that went into it, that I won't belabor here. So as the CAC progressed, also how we managed asthma sort of changed and progressed. So again, there was an update in 2002, and then the expert report 3 came out in 2007, which was actually a more complex and a big change in the way we manage asthma. So again, basically the 2002 was an update in selected topics, mainly the use of inhaled corticosteroids in children, combination therapies, and also the use of antibiotics in certain circumstances, as well as monitoring and prevention. Expert report 3 was a major change in the approach to asthma, a much more sophisticated way of treating asthma, basically due to a better understanding of the physiology of asthma. It emphasized the importance of allergens and morbidity control of asthma, and outlined testing methods for allergen testing, but also included newer asthma therapies such as anti-IgE therapy, and defined roles and treatment for those therapies. And basically emphasize the idea of control of asthma rather than severity. And I'll show you why that was a step forward in just a second in some of the slides we'll look at here. So basically the key elements were assessment and monitoring of severity, control, and response to treatment. So severity was emphasized for initiating therapy, control emphasized for monitoring and adjusting therapy, and severity and control defined in terms of 2 domains, which was both impairment and risk. Which goes along with the idea in asthma, that the fact that you have a low FEV1 doesn't necessarily mean that you're going to be symptomatic. Some patients can be very sick and not know it. They'll have a very low FEV1. Some patients will have a fairly normal FEV1, but have lots of symptoms. And again, this version of the guidelines recognize that you need to treat both of those. So severity really is the intrinsic intensity of the disease progress and process, and sort of corresponded to that original 4 severity steps that they talked about in the original guidelines, and guides clinical decision making mostly during the initial evaluation before the start of controller therapy. And it's most easily measured before you start therapy, because once you start therapy, what you really care about is control, the degree to which symptoms, impairment, and risk of exacerbations are minimized as the goals of therapy are met, and used to guide whether to maintain or adjust therapy. A responsiveness is the ease to which asthma control is achieved by therapy, and responsive therapy can be very highly variable among people. So in the original guidelines, all 3 are sort of combined into that 1 4-step schema. And here it's sort of actually breaking out different sort of components of asthma care. So basically, still have the incorporating 4 components: care, assessment and monitoring, education, intervention on environmental and comorbid conditions, and medications. You initiate therapy based on asthma therapy, and then you adjust it based on asthma control. They also sort of broke into new age groups. So in the original guidelines, if you saw that initial table I showed you, basically it was 5 and above was who you're treating. So this actually had 3 different age groups: 0 to 4, 5 to 11, and 12 and up. Increased the number of steps with therapy from 4 up to 6. elimination of mild when discovering intermittent patients, because obviously they can have exacerbations of any severity. And we redefined preferred medications within each step. Inhaled corticosteroid remained the preferred long-term controller therapy. And despite fears of long-acting beta agonists, and we'll talk about this just in a little bit, long-acting beta agonists, inhaled corticosteroids remain the preferred therapy as opposed to increasing ICS dose. Again, they talked about the first biologicals, which was anti-IG therapy at steps 5 and 6 for those with clear allergic disease. And again, these are fairly busy tables, but this again just kind of showed you sort of how you would sort of treat asthma. And again, instead of those 4 steps we talked about in the expert report 2, they had 6 steps along with sort of education of the other components that we talked about within the care. But the big breakthrough on here was the idea of how you would assess control. And again, so assessing controlled therapy, so well-controlled, not well-controlled, and very poorly controlled, really would be based on symptoms, nighttime awakenings, beta agonist use, much as the way you would sort of initially assess severity before you started therapy, but also incorporated actually validated questionnaires such as the asthma control test in order to actually, as you see patients in each group, you would then be able to look at their impairment and then also assess the risk based on the number of exacerbations per year. It would give recommendations about what to do in response to those that control. And again, not just going up 1 step, but in this case, stepping up 1 to 2 steps and when you should reevaluate based on control. Again, the first set of guidelines, we were able to put these little pocket cards that you could fit everything on a card. This was complex enough. We actually sort of worked with organizations such as Erie Family Health, who initiated a sort of a computer-based assistance for their electronic medical record in order to help guide therapies, because it sort of was hard to do sort of on a basic level with just a set of pocket cards. More recently, the expert report 4 came out, which is basically that group met in 2018, just before the pandemic, and then released the report during the pandemic, and basically updated 6 specific topics. So rather than sort of start from scratch and sort of redo the entire guidelines, they sort of focused on a series of specific topics. They use grade methodology, which is in vogue now as sort of being the most transparent and rigorous methodology for guidelines formation. And some overlap with the international GINA guidelines. And again, these are the sort of corresponding to the 6 steps we talk about. These are the 6 things they talk about. And the thing that's most interesting in these guidelines is actually the role of long-acting beta agonists and how that's changed over time. So again, early in the CAC, long-acting beta agonists got a bad name. There was a study called the SMART study, where Glaxo was thinking that long-acting beta agonists might have some intrinsic anti-inflammatory property, and they were looking at sort of adding on long-acting beta agonists in a controlled fashion on top of patients' usual therapy. Unfortunately, they really didn't record very well what that usual therapy was, and found that patients who were on long-acting beta therapy actually had excess death, especially in African Americans. Now, it turns out a lot of that may have been the fact that it was patients taking long-acting beta agonists on no inhaled steroids were probably the group most at risk. But more recent data is actually found that using a different formulation of an ICS formoterol, or Symbicort is the brand name of that drug. They looked at patients 12 and above using Symbicort or ICS formoterol as a single inhaler, both as their reliever and controller on an as-needed basis. It found that overall ICS dose and number of exacerbations decreased, which is sort of anathema to what we have done back in sort of 1997 or early 2000s. They also have had other groups looking at numerous studies in school-age children, 6 and above, and unfortunately they talked about SMART therapy. I think they would have sort of avoided that name given the initial trial that sort of caused so much trouble in the first place. So again, Big change is the use of long-acting beta from anathema to sort of now sort of entrenched in the guidelines as a as-needed therapy. Role of tiotropium. Tiotropium is another drug that's been sort of used in COPD, but now found to be used in asthma. It blocks M1 and M2 receptors. Step 4 of 5 in GINA, and not included in EPR3 until 2007, and finds that it's for certain genotypes may actually improve care in those patients who may be Th2 low, those with lots of sputum neutrophils. Expected outcomes were shown to increase on patients on tiotropium. The biologics could be basically something I could talk about an entire lecture on, that basically have exploded on the scene and to such extent that actually they're not really addressed very fully, even the most recent guidelines, and basically block certain pathways. The most important one is IL-5, which is the cytokine that nurtures eosinophils, the cell that's involved in asthma. Omalizumab with the anti-Ig therapy that's been around for a while is the antibody that's involved in asthma. A big change over the years is the advent of HFA inhalers. Back in the day, we would use chlorofluorocarbons to power our refrigerators, our air conditioners, and our inhalers. Basically, that was banned in the Montreal Protocol in 1987 due to destruction of the ozone layer. Meter dose inhalers were given a grace period, but in 2009, FDA banned the use of CFC inhalers. HFA replaced CFCs with proliferative inhalers, and generic albuterol unfortunately disappeared from the market at that time. So again, spacers were used when CFCs were around because they had a relatively large droplet size, and spacers provided time and space for those droplets to evaporate. But basically, HFA inhalers, when they were designed to have a smaller particle size, and spacers were no longer universally required, which comes to a shock to many sort of long-term asthma education folks. Again, only used now for people who have trouble with timing. But there's still need for device education because there's been a multiplicity of devices that came out, mostly the dry powder devices, because when a drug maker comes out with a new drug, they also can patent the device that delivers that drug, discouraging them from being similar. Asthma environment could be a whole other lecture, but I've run out of time. But basically, all of the NAAP guidelines have emphasized asthma interventions, especially home environmental interventions. And Vicky Persky was part of the group, Lenore Coover, doing home evaluations to improve environment within the home. We also looked at the outdoor environment through a EPA grant called CISIS that I did at U of C, looking at ozone and particulates. But again, a newer issue that's come on the scene, especially with the advent of violence and other sort of issues within the inner city, are the idea of adverse childhood experiences in childhood. Again, these have found to be actually associated with increases in inflammation, correlated with ACE exposure, has been correlated with worsening asthma and childhood asthma. And it's found that these ACEs have been sort of additive to environmental factors. Approaches have been taken to mitigate ACEs have been identified. Again, another thing that we consider along with environment, not just the physical environment, but the psychological environment as well. So what has changed over the time of the CAC? So treatment approaches, medications, and devices, as well as our overall approach. But what hasn't changed is basically the need for CAC, which again, glad you're all still here to carry on the torch. And thanks again for letting me speak. I believe whoever is speaking is muted.
Okay, Sarah, do I get to say something? Okay, this is great. First of all, Ted, thank you. This is a fast hour. There's so much information that you and Sydney shared, and it's absolutely incredible. And your old pictures made me remember an inhaler from years yore called Primatine Mist, if you remember that one. And I was just, I was remarking to myself that there was a time when, certain like lavas had a black box warning and Primatine Mist was over the counter. It's like, whoa, we've come a long way. Yeah, thank you, Sharmali. It is still available, but so anyway, thank you very much for your presentation. I've been looking forward to this particular subset of this program since I heard that we were doing this about 2 months ago, the Lifetime Achievement Award. And I'm not presenting the person who's getting the award, I'm just presenting the award itself. So, for Chicago Asthma Consortium's 25th anniversary, we thought that it would be a good opportunity to just reflect on some of the people who really we could not have come this far this fast without their contributions to science or to just clinical practice in asthma. And so we put together a group of people who were vetting applications, and we had a competitive process to figure out if there were a couple of people around Chicago who we could bestow awards on to just represent our gratitude for the work that they did over their, in this case, lifetime, to help advance our study of asthma in the context that it's in. So that's how this Lifetime Achievement Award came to be. We had a competitive awards process. There were a bunch of different people who were excellent nominees. And we chose one from amongst their midst, or I should say I was not part of the choosing committee, but CAC more generally chose. And I think the person we came up with is someone very special and certainly very deserving. And to announce that person's name, because I won't be doing it, I'm gonna pass it over to Kamal. Or do I pass it to you, Sarah, to announce Kamal? I could just send it to him?
You can send it right to Kamal.
This is great. Okay, then I'll pass it over to Kamal to announce the winner.
Good evening. It is my distinct honor and pleasure to introduce my advisor, mentor, and friend, Dr. Victoria Persky, the recipient of the Chicago Asthma Consortium's highest honor, the 2021 Lifetime Achievement Award. Dr. Persky, MD and Professor of Epidemiology at the School of Public Health at the University of Illinois at Chicago. Dr. Persky has over 40 years of experience in chronic disease epidemiology and community outreach and engagement programs, especially those related to respiratory and environmental health. She has been principal or co-investigator on more than 50 funded grants. Dr. Persky is a sincere and very passionate community advocate who is dedicated to creating healthier communities through community-driven research and interventions that take into account the input and needs of the communities she has worked with. Dr. Persky has also contributed to the training and education of hundreds, if not thousands, of students, scholars, researchers, and community advocates, advancing science and making a huge positive impact on communities here in Chicago, the United States, and globally. I first met Vicki in 1998 or 1999 as a student in her class, and she impressed me with her great passion for empowering and protecting communities. Then for over 20 years, Vicki has been a great instructor, advisor, mentor, and collaborator for me. During these years, I witnessed firsthand how Vicki has advocated fiercely and fearlessly for social justice in Chicago and beyond. Please join me in congratulating Dr. Vicki Persky for this prestigious award.
Oh, thank you, Kamal. And it's
it's wonderful to see all these old friends, Sydney and Jim for funding the CAC, and all the many people on this call today with whom I've related over the years. And thank you so much, Kamal. That was just a lovely, lovely talk.
Vicki, do you have the award by you?
I can go get it. Oh,
I
we'll go
need
get
to.
it. 1 second. It's beautiful. Most awards are okay. This one's stunningly. My husband just went to get it. Thank you. It's funny. I was listening to Sydney Parker. I was remembering the school committee from 25 years ago, and how very frightened I was after my first Chicago asthma prevalence study, followed by Ruchi Gupta many years later. And it was a difficult board then in the school board. And I remember Whitney Addington dragging me down to the school board to make sure that we could actually work with the schools, which turned out to be a true joy. You know, getting that inhaler law passed was actually a lot of fun. This is the award. It is stunningly beautiful. Wait a minute, I'm trying to get it here. How do I?
Hold it higher.
Higher, here it is. Here it is. It's really beautiful. Whoever chose this, it's absolutely beautiful. Thank you so much.
We appreciate you, Dr. Persky. Thank you.
Thank you. Bye.
Bye-bye. And now we can turn things over to Crystal Stevenson for the next award.
Hi, hello everyone. And again, thank you for being here. I am totally honored and humbled to be able to present our Outstanding Service Award to someone who is not only a colleague, but I consider her a friend. This person, her name is Dr. Sharmili Nineheis. And I'd like to share a little bit about her background. She's a physician of allergy and immunology at the University of Illinois Health, as well as at the Jesse Brown VA Medical Center. And she also serves as an associate professor of medicine at UIC. Now, she joined the CAC board back in 2011, and since then, she's been a very active member, not only working on various committees, but also in the capacity in the executive role as a past chair, a chair, and even as a secretary. She, on the various committees that she worked on included the Professional Development Committee, and she also helped to build the Community Advisory Board. And currently, she co-chairs the newly developed Community Education Committee. So Dr. Nineheis, is committed to addressing disparities in unique and minority populations with asthma. Her research portfolio has included work around understanding reasons for increased asthma severity in older adults, to working with urban populations who have recurrent emergency room visits for asthma. And she is currently working in identifying barriers to physical activity among African-American women with asthma. Her overall goal is to expand our knowledge of lifestyle behavior change in asthma to improve the lives of minority asthma populations. Her work is funded through the National Institutes of Health, Lung, and Blood, and the National Institute on Environmental Health Sciences. And she's currently a co-investigator for PRECISE, which stands for the Precision Interventions for Severe and/or Exacerbation-Prone Asthma Network. Currently, in addition to all this other work, she also runs an asthma support group for adults at the University of Illinois Health Systems, where she provides education on health-related topics. Again, I'm so honored to present this service award for Dr. Sharmili Nineheis. So thank you very much. And
thank you so much, Crystal. This is the award to show everybody, but I'm definitely very honored to receive this award. And Just a little bit, I came to Chicago to join the faculty at UIC and at the end of 2009. And, some of my colleagues at UIC, Lisa Sharp, she had said, "Oh, you got to come to this, CAC meeting." I didn't really know what CAC was at the time. It was a professional development meeting, but I was just in awe of the collaboration that I saw across the city on asthma. And so Lisa suggested that I become a board member. And again, I really enjoyed meeting a lot of the people that, spoke today, and just have been, humbled in the work that the CAC has done, and have been so happy to contribute to it. And I just feel like the CAC, I hope it continues to grow and, and continue to do all the great work that it has done. And I know, our role has kind of morphed and changed over the years, but I think still the core mission is still in the hearts of our members as well as our board. So again, thank you so much for this honor, and I again thank you for everyone that has shown up tonight. That it's been really great to see so many people that have contributed to CAC. Thank you.
Thank you, Sharmili, and congratulations on your service award. It looks like we're at the end of the hour, and not to be repetitive, but as Matt said, this was a quick hour. We would love to send some thanks before we end tonight's program, especially our partner level sponsors. As you can see here, the Asthma and Allergy Foundation of America, the American Lung Association, and Northwestern University's Feinberg School of Medicine Center for Food Allergy and Asthma Research, also the CFAR. We also would like to thank our advocate level sponsors, as you can see here, and our support level sponsor. We'd also like to just thank our community partners that you see here, whose support enables all of our work and programming. And you can always find more information about our community partners by visiting our website at chicagoasthma.org. Lastly, and most importantly, I would just like to thank everyone that's participated in tonight's event. And for those that have led the history and started and set the examples for all of us that continue to work in asthma and health equity around the Chicagoland area and beyond. So those of you that have joined us today as speakers, as participants, the board currently of the CAC, those that are helping to support the consortium, we are all greatly thankful for everything that you continue to do. I would like to just remind folks, if you are not already a member of the Chicago Asthma Consortium, look at all the fun you're missing. You should join. Please, as I mentioned, visit our website at chicagoasthma.org, where you can sign up. There's a number of different levels pertaining to different costs. If you're a student or a professional or what have you, please, take a look and see what works best for you. You'll also have access to all of our upcoming presentations, events, and other sorts of resources, including our new tenant checklist, which is fantastic, and I wish I had in 2007. And we can also provide you, you can find some of these resources online. You can print them off. We can send you copies, just let us know. And then lastly, we are on social media, because who isn't anymore? So please feel free to join us or follow us on social media. Some of the links are being provided to you right now in the chat. I wish you all a wonderful and healthy end of your year. This has been a trying 21 months. And I especially want to give so much thanks to those that continue to work towards managing our COVID-19 pandemic, and also working towards an equitable health system in the Chicagoland area. So my thanks to today's speakers and participants, and wishing you all a wonderful end of your year, and may it be healthy and peace-filled. Thank you.